So moving on next to Luis Mendez from Clinica Alemana. And the talk title here is Approaching Complementary Studies for Timely and Accurate Diagnosis of Cirrhosis from Primary Care to Specialty Consultation. Luis specialized in internal medicine at the Chilean Air Force Hospital before he joined the subspecialty of gastroenterology at Pontificia University in Chile. He currently works in the gastroenterology service in Clinica Alemana de Santiago and the Hospital Padre Hurtado.
Hello everyone, my name is Luis Mendez. I'm very grateful for the invitation. It's an honor for me to give this presentation. I want to start with a short sentence from the beginning of the medicine. A hard liver in jaundice is a bad sign. This short sentence is full of wisdom, I think. I work in Santiago de Chile in two centers, Clinica Alemana and Hospital Padre Hurtado, and my conference is approaching to complementary studies for timely and accurate diagnosis of cirrhosis. That's my disclosure. I want to share with you a couple features of Chile. My country is placed in South America, next to Peru, Bolivia, and Argentina. We are famous because you can find very good and cheap fruits in Chile, good wine, and in the past we had very strong earthquakes in order to lower health problems. We have many cases yearly of gallbladder cancer and gastric cancer. Another number that you need to know is our population is near to 20 million inhabitants with a high life expectancy at birth with low infant mortality rate. In the past, we had two poetry Nobel Prize, Gabriela Mistral and Pablo Neruda, and since a few years ago, we have the largest radio telescope in the world, in the north of the country. And maybe you know Alexis Sanchez, our very famous soccer player. This is my route to the conference. We review some clinical features of cirrhosis and the need for an accurate diagnosis, and new possibility for non-invasive tests and results and projections. Cirrhosis is a very big global health problem with more than 100 people affected. Each year, more than 11 million patients suffer decompensate cirrhosis, need hospitalization or even die. Near to 1 million suffering hepatocarcinoma, and liver transplant is a small number in comparison to the bigger one. You must keep in mind that it's a very complex phenomena with social impact, because advanced disease present with emergency sometimes, bleeding, encephalopathy, ascites, hepatorenal syndrome, or cancer. The liver damage is very common with multiple etiology, like alcohol, viruses, steatosis, autoimmune disease. And social impact is very spread with traffic accidents, family disruption, an example. We have a gold standard, but it's very bad to have the whole liver on your table. So we perform liver biopsy with a needle puncture, but this procedure is expensive and has risk associated like bleeding and pain with a sampling error. Sometimes the diagnosis of cirrhosis is very easy, and it can be made by the security staff in my hospital. Because if the patient presents with jaundice, ascites, red palms, the diagnosis is very easy. But the physical signs are not present in most of cases, and in this table you can see the sensitivity and specificity of the usual signs that we look for in our patients. Clinical examination is not enough. The physical signs are generally of low sensitivity for diagnosis. Signs with higher specificity are associated with clinical decompensate and advanced disease. Sometimes the diagnosis present at the worst possible time, like intraoperative during pregnancy, just before starting chemotherapy, or following a traffic accident. Other times we need to perform an assessment of the surgery risk because advanced fibrosis may increase post-operative hepatic decompensation, and it can be difficult and costly to use multiple parameters to facilitate the decision making, like imaging, endoscopy, liver stiffness parameters. Usually we need to monitor the progression in our patient under treatment, like autoimmune hepatitis overlapping, or the combination with steroid users and NASH. Patient on potentially hepatotoxic drugs like methotrexate or cancer chemotherapy also need to know how's the performance, the whole performance of the liver function. Laboratory tests are a very good option because are simple, in low cost, non-risk, and there are validated scores for severity and prognosis, and are very useful in advanced cases and decompensation. But in early stage, it's not the same. It was performed in early fibrosis. In many patients with cirrhosis have normal lab tests and normal physical examination. FIB4 score is a little better than other simple non-invasive tests, but not perfect. Specificity decline with age and is very low after 65 years old. Imaging, ultrasound without risk, acceptable cost, is operator dependent. CT scan is a high cost with radiation exposure and required contrast. MRA is high cost test with limited access for primary care or far areas, rural areas. So imaging tests are not perfect for assess a good diagnosis for cirrhosis. Other method is to evaluate the liver stiffness, like a FibroScan is very good exam that is safe, simple, with moderate cost, but it's the access is not open for non-specialty clinics. And in obesity patients reduce the performance. MR elastography is an excellent test to detect fibrosis, but it's very expensive with limited access. This is the front of my hospital. Unfortunately, in my hospital, don't have MRA, don't have FibroScan. Ultrasound and CT scan is difficult to perform because we have a waiting list, and we receive decompensate patients every day. This is a picture of a real patient with acute very short bleeding. Sometimes I feel in the desert. This is a picture of Death Valley, San Pedro de Atacama, north of the country. If we're looking for an ideal test, we need some features like non-expensive, non-invasive, good predictive capacity, and detection in early and late stage. Maybe we can look for the smell of cirrhosis. In this remarkable study, Giuseppe Ferrandino showed that patients with cirrhosis present elevated concentrations of limonene in breath samples. And many other groups showed the same results. And the breath levels of limonene decrease after transplant, after liver transplant. So we can think that limonene can be useful to estimate the liver function. After a few emails, we have now a network. Recently we finished our first protocol between Hospital Padre Hurtado, Clinica Alemana, my both centers where I work, and Institute of Science and Innovation in Medicine of my university, and also medical. We create a protocol approved by ethical committee, and we include a patient with compensated cirrhosis and controls, healthy controls without liver cirrhosis in ultrasound and normal lab test. We exclude pregnancy, the patient with decompensated or illness, acute illness, encephalopathy, or difficult to use a mask or breathless. In our protocol, the patient were invited to the hospital and the Clinica Alemana at fasting without use citrus day before, and we take something for breath collection, receive a breath sampling, and at baseline and after ingestion of limonene 100 milligrams by oral route, and they must to use the mask during 5 minutes, and we make the collection of breath samples after 20, 40, 60 minutes, and at the finish we took a ambient sampling. This is the steps of our study. In the left side, our team, next to receive a kit and the finish in UK, we perform the biochemical analysis. This is table 1. We can recruit 29 participants per arm. Most of their demographical characteristics were similar, but not the age. The cirrhotic patients were some older than the controls. And this is the most beautiful curve after intake the 100 milligrams of limonene. The cirrhotic patients show a very high peak of limonene in breath sampling, quite different to the controls. And we analyzed these different time points to choose the best performing to separate both populations. And we find that at 60 minutes, we get the best perform with this very good sensitivity and specificity, with a very good likelihood rate. So we can expect this test can be in the future and a tool for evaluate the liver function has a non-invasive test. This is a landscape for the south of the country, Torres del Paine National Park. That's my last slides. Cirrhosis is a major global health problem. As a clinical assessment is not enough. We need to more accurate, less expensive, non-invasive methods to measure liver function. There is a big task for researchers. And finally, if you go to Easter Island, you can see Ahu Tongariki, like a very good team, like over. Thank you very much.
Thank you for joining from, I know the time zone difference, it's quite big for you, so we really appreciate you joining for the questions. So we've got time for questions now. Again, post it in the Q&A. I was going to kick this off with one. So I think what I found particularly interesting was actually if cirrhosis is detected at a compensated stage, then there are things that can be done for the patients compared to it getting to a decompensated stage. So I was wondering if you could elaborate further on outcomes from a patient perspective if you are able to pick up cirrhosis at an earlier stage.
The main situation is that our available tests for clinical assessment are not so perfect. But when we detect some alteration, we can go and move on for the next step to rule out with imaging or another test. But not always the patient can get the fast or simple. That's the reason why we need to look for another option for detection. And when you find a patient with advanced liver disease, you can perform a best follow-up program. You can be strongly recommended to stop alcohol and modify the drug daily schedule.
Yeah, no, that's fascinating. I think because we had done a lot of work previously in cancer detection, then the outcomes are so bad at a later stage of disease. But it does seem here that picking up patients at the earlier stage of cirrhosis, there's certainly going to be improved outcomes for them. Giuseppe is on the line as well. I'm wondering if you could elaborate further on the choice of limonene as a compound. So what's the biological rationale that then explains the findings where you have elevated levels of limonene in cases of cirrhosis relative to controls?
Yeah, so limonene has the dual feature that it is widely used for different purposes. So we are highly exposed, and then it is metabolized in the liver and it is exhaled in the breath. And in particular in the liver, it is metabolized by the CYP system. And for these reasons, probably it's one of the compounds that has been mostly identified in all the studies that have been conducted so far. And therefore, it's a robust potential biomarker associated with liver disease. We also have the data from Professor Chris Mayhew, showing that after liver transplant, the levels of limonene go down, suggesting that it is a liver. So that the increased levels in subjects with cirrhosis is related to the liver disease. So yeah, and then basically limonene has been our initial compound to test with this approach for several of these reasons. And then another aspect is also the safety, because it can be administered with large doses to the subjects, because the safety is very well established. But of course, besides limonene, we can also use additional compounds that are metabolized by different metabolic pathways. And with Luis, we are doing this right now. We are collecting, we have already data from 6 subjects with and 6 controls, 6 patients and 6 controls. But this is these results are coming in the future, so will be shown in the future.
Brilliant, thank you. Next question for Luis is, I think you touched on a little bit about some of the diagnostic challenges, particularly for obese patients. I'm wondering if you could elaborate a bit further there on some of the specific challenges, because I could well imagine obesity is present in quite a large number of the patients there.
Yes, it's a best question. We have many difficulties. First, transplant, liver transplant is very difficult in our country. Our yearly we not reach 200 cases for cirrhosis. Second, the increase of the alcohol intake after pandemic and diabetes, we are overwhelming with the numbers every day, and maybe the best setting for this test will be in the primary care or in patients with some risk factor, and there will be a very good option. Also, limonene is very safe, and I do the test also. It's good taste and it's not risky. And maybe in the future we can offer a shorter test, not for 2 hours, maybe shorter.
Yeah, I think that's an important point, because actually some of the kits that are already supplied in GI disease allow for home-based collection after ingestion of a substrate. So I would imagine here, that similar path is open for this type of diagnosis. Next question, I think aimed at you again. Does it look like the concentration of the limonene relates to disease severity?
We are looking for the best explanation. At the base, really I have my expectancy. It was to find different slope of the elimination, but our finding was the different peak. Maybe you see people help us to explain the reason why, but also we find it correlates with fibrosis. Maybe the next step is to evaluate if our test can be correlated with different stage of fibrosis, with maybe head-to-head with FibroScan or another method.
Great. Next question, maybe both of you could try and tackle this one. In the context of cirrhosis, how might genetic predisposition interact with dietary and environmental factors to influence VOCs and breath analysis? And are there any specific VOCs that could shed light on the interplay between genetics and environment?
This is a very good question. Our study was setting in the real world. We haven't access to genetics markers or our basic study for all the patients is to detect virus, autoimmune hepatitis, NASH, alcoholic, and iron deposit. But maybe exist others disease that can get into cirrhosis, but we have not information about that, because our main skill are clinicals. But it's very good point. Maybe can exist genetic variants that can explain different patterns.
Brilliant. Giuseppe, anything to add to that?
Yes, so there are genetic variants, for example, that have been widely characterized, for example, in non-alcoholic steatohepatitis, where the environmental factors are very important in the progression of the disease. For example, obesity and a sedentary lifestyle. And so overall, we can, with the compounds that we have now, we can look at how the liver is basically progressing to an advanced stage of liver disease in this condition. But of course, finding VOCs that may be associated with this genetic variant may be valuable, because these people are at higher risk of developing a liver disease.
Got it. Next question, probably for you, Giuseppe. What's the advantage of using multiple probes at the same time? So obviously we focus on limonene here.
Yeah, so for example, if we consider limonene, it is metabolized by CYPs, and there may be people that have CYP variants that metabolize it faster. And therefore, if they are subjects with cirrhosis, may result as false negative because their liver is coping with limonene very well. However, if we use additional compounds, we can probe additional metabolic pathways at the same time. And therefore, the risk of having subjects that are highly metabolized of those metabolic pathways all in the same subject is much lower than when we use one substrate alone.
That's interesting. So does that mean you could also potentially use this approach to identify who extensive metabolizers of certain drugs? So as well as thinking about the diagnostic application, could you use these as surrogates for a drug, how they would metabolize?
Yeah, so this may be an additional approach of these VOCs to see how well the subjects are metabolizing the compounds, although the genotype not always corresponds to the phenotype, because, for example, the property of the compound, so how the liver extracts the compound from the blood, is one of the elements that affect the rate of the metabolism of the compound. So therefore, having a phenotype and not a genotype may be more helpful in terms of, for example, applying this approach to pharmacokinetics, for example.
Yeah, there's plenty of examples of phenoconversion that happens. Excellent. We've got to leave it there. Thank you so much, Luis and Giuseppe, for the talk and the Q&A.